Gentlemen, a 64-year-old patient named Robert came into my clinic about 18 months ago. Retired accountant, careful man, the kind of man who followed every instruction his doctors gave him, took every medication they prescribed, and did everything he was supposed to do. He sat across from me looking genuinely confused and quietly devastated and said, "Dr. Carter, I've done everything right. I exercise, I watch what I eat, I take my medications exactly as prescribed. So why do I feel like I'm disappearing? The energy is gone. The drive is gone. My wife and I haven't been intimate in 4 months, and nobody can tell me why." Nobody had told Robert to look at what was sitting in his medicine cabinet. He was on 5 medications, all of them prescribed by physicians he trusted, all of them for legitimate, real conditions. And collectively, silently, without a single warning conversation, 3 of those 5 were doing measurable damage to his testosterone levels, his circulation, his sexual function, and his sense of himself as a man. Not because his doctors were negligent, but because the intersection of male hormonal health and common medications is one of the most under-discussed topics in all of men's medicine. And the men paying the price for that silence are sitting in my clinic every single week. If you are over 50, if you are on 1 or more prescription medications, and if you have noticed changes in your energy, your drive, your erectile function, or your sense of vitality that you cannot fully explain, stay with me. Because what I'm going to share today could be the most important conversation about your health that nobody has thought to have with you yet. I'm Dr. Emily Carter, a board-certified urologist with over 14 years of experience helping men over 50 protect and restore their hormonal health, their sexual function, and their physical vitality. I want to challenge something you may have been told, or more accurately, something you may never have been told at all, that the medications keeping your blood pressure controlled, your mood stable, or your prostate comfortable are completely without consequence for your male health. In my clinical experience and in the research I follow closely, that assumption is far more costly than most men realize. Your body has the right to a complete picture. Today, I'm going to give you one. Before we go any further, I need to say something clearly, and I need you to hear it. Nothing in this video is a recommendation to stop taking any prescribed medication. Please hear that. Some of these medications are keeping men alive. They are managing conditions that, left uncontrolled, carry serious consequences. What this video is, what it is designed to be, is the conversation your prescribing physician may not have had time to have with you. Information that empowers you to ask better questions, advocate for your own health, and have an informed discussion with your doctor about whether alternatives, adjustments, or supportive strategies might be appropriate for your specific situation. Knowledge is not danger. Uninformed silence is. Before we go any further, hit that like button and drop a comment telling me how many medications you are currently taking. I want to know. And I want every man watching to realize he is not alone in this conversation. Now, here is what is happening inside the male body, specifically after 50, that makes this conversation so critical. After 50, your hormonal system has less reserve capacity than it did at 35. Your testosterone is lower. Your nitric oxide production has declined. Your liver's metabolic processing has slowed. Your cardiovascular system is operating with less margin. This means that a medication which a 38-year-old man might tolerate with minimal hormonal consequence can produce a dramatically different effect in a 62-year-old man whose system has less capacity to compensate. The pharmacological effect is the same. The hormonal environment receiving that effect is entirely different. And that difference is what most prescribing conversations fail to account for. This is the context in which I want to walk you through 5 categories of medication that are silently, and in many cases significantly, affecting male health in men over 50. Not to alarm you, to equip you. Number 1, beta blockers. Beta blockers are among the most widely prescribed medications in the world. Metoprolol, atenolol, carvedilol, propranolol. If you are managing high blood pressure, heart disease, heart rhythm abnormalities, or even migraines, there is a meaningful chance you are taking one of these. And there is an equally meaningful chance that no one told you what they do to male sexual health. Biologically, beta blockers work by blocking the effect of adrenaline on beta adrenergic receptors throughout the body, slowing the heart rate, reducing blood pressure, and decreasing the force of cardiac contraction. The problem for male sexual function is that these same receptors are involved in the neurological signaling that initiates and maintains erection. Beta blockers reduce the sensitivity of the vascular system to the signals that drive penile blood flow. They also cross the blood-brain barrier, particularly propranolol, and suppress the central nervous system components of sexual desire and arousal. Research published in the journal Hypertension and confirmed across multiple subsequent studies has shown that men on beta blockers have erectile dysfunction rates 2 to 4 times higher than men on other classes of antihypertensive medication. Sexual side effects are among the leading reasons men discontinue beta blockers, often without telling their doctors, which creates its own set of dangerous consequences. Beyond erectile function, some beta blockers, particularly the older non-selective types, have been associated with modest reductions in testosterone levels over time, and more consistently with fatigue, reduced exercise capacity, and a blunted sense of vitality that men frequently attribute to aging rather than medication. Emotionally, this matters in ways that extend far beyond the physical. When a man's sexual function declines and he doesn't know why, the narrative he builds around that decline is almost always personal. He concludes something is wrong with him, with his relationship, with his age. The shame and the withdrawal that follow from that false narrative are genuinely damaging to men, to their partners, to their marriages. Robert, the patient I mentioned at the beginning, had been quietly withdrawing from his wife for months because he believed his body had simply stopped working. When I told him that his beta blocker was a primary contributor, something shifted in his face that I have seen many times. Not just relief, grief. For the months of unnecessary distance, for the story he had been telling himself that was never true. Practically, if you are on a beta blocker and experiencing sexual side effects, ask your physician specifically about nebivolol, a newer, highly selective beta blocker with a unique mechanism that actually increases nitric oxide production rather than impairing it. Multiple studies have shown that nebivolol has a significantly better sexual side effect profile than older beta blockers, and in some trials was associated with improved erectile function compared to baseline. This is not a reason to switch without consultation. It is a reason to have the conversation. Number 2, thiazide diuretics, hydrochlorothiazide, chlorthalidone, indapamide. These water pills are among the most commonly prescribed first-line treatments for high blood pressure, and they appear benign. They just help you urinate more. How could that affect male health? Biologically, the mechanism is more direct than most men realize. Thiazide diuretics reduce blood volume and lower blood pressure by increasing urinary excretion of sodium and water. But they also increase urinary excretion of zinc, and as I discussed in a previous video, zinc is foundational to testosterone biosynthesis. Chronic thiazide use produces a measurable, progressive zinc depletion that directly impairs the enzyme systems involved in testosterone production. Studies have documented testosterone reductions in men on long-term thiazide therapy that are clinically significant, not catastrophic in isolation, but deeply meaningful in the context of a man over 50 whose testosterone is already declining at 1 to 2% per year. Beyond zinc depletion, thiazide diuretics have a direct vasodilatory effect on peripheral circulation that, counterintuitively, can impair the localized pressure dynamics required for firm erection. A comprehensive review in the Journal of Urology identified thiazide diuretics as having one of the highest rates of sexual dysfunction among all antihypertensive drug classes. Yet they remain among the most reflexively prescribed. Practically, if you are on a thiazide diuretic, 2 conversations with your physician are worth having. First, is zinc supplementation appropriate to compensate for urinary losses? 15 to 25 milligrams of zinc glycinate daily is a reasonable, safe, evidence-supported addition for men on long-term thiazide therapy. Second, are alternative antihypertensive classes, ACE inhibitors, ARBs, or calcium channel blockers, appropriate for your specific situation? ARBs in particular, specifically losartan, have been associated in research with neutral to positive effects on erectile function and have largely replaced thiazides as a preferred first-line option in men with sexual health concerns. Number 3, statins. This one is more nuanced and more contested than the others, and I want to be honest with you about the complexity. Statins are prescribed to tens of millions of men over 50 for cholesterol management and cardiovascular risk reduction. Atorvastatin, rosuvastatin, simvastatin, the likelihood that you or a man close to you is on one of these is very high. The controversy around statins and testosterone is real and ongoing in the medical literature. Here is what the evidence shows. Cholesterol is the direct precursor to testosterone. Your body synthesizes testosterone from cholesterol through a multi-step enzymatic process. Statins work by inhibiting HMG-CoA reductase, the enzyme that drives cholesterol synthesis. By lowering cholesterol production, statins theoretically reduce the substrate available for testosterone synthesis. Several studies, including a large analysis published in the journal PLOS One, examining data from over 3,000 men, have found associations between statin use and lower testosterone levels. Other studies have found neutral or even modest positive effects, likely because improved cardiovascular health supports better endothelial function and nitric oxide availability. What is less contested is the musculoskeletal effect. Statin-related myopathy, muscle pain, weakness, and fatigue affects a meaningful percentage of men on these medications, with estimates ranging from 5 to 25%, depending on the study and the statin dose. For men over 50, this muscle-related fatigue is frequently indistinguishable from aging-related decline. It suppresses exercise capacity, reduces testosterone-stimulating physical activity, promotes fat accumulation, and creates a secondary hormonal decline through the mechanisms I described earlier. It is a cascade that begins with a medication side effect and ends with a man who feels decades older than he should. Practically, if you are on a statin and experiencing significant muscle fatigue or have noticed hormonal changes, ask your physician about CoQ10 supplementation, 100 to 200 milligrams daily, which has evidence supporting reduction of statin-related muscle symptoms. Ask about your specific statin and dose, as pravastatin and fluvastatin have shown lower rates of muscle-related side effects in comparative studies. And ensure your testosterone levels are being monitored, not assumed. I want to be clear. For men with established cardiovascular disease or very high cardiovascular risk, statins save lives. The conversation is not whether to take them for those men. The conversation is how to take them most intelligently while protecting as much hormonal health as possible. Number 4, antidepressants and anti-anxiety medications, specifically SSRIs and benzodiazepines. I approach this category with particular care because mental health is real, depression is real, and the medications that treat these conditions are genuinely important. This is not an argument against treating mental health. It is an argument for treating it with the fullest possible picture. Biologically, SSRIs, selective serotonin reuptake inhibitors such as sertraline, fluoxetine, paroxetine, and escitalopram, increase serotonin availability in the brain and nervous system. This is the mechanism that reduces depression and anxiety. The same mechanism, however, suppresses dopamine signaling, and dopamine is the primary neurochemical driver of sexual desire, motivation, and the reward circuitry associated with intimacy. SSRIs are associated with sexual dysfunction in somewhere between 30 and 70% of men who take them, depending on the specific medication and dose. The dysfunction takes several forms: reduced libido, delayed or absent orgasm, and in some men, a phenomenon called emotional blunting, a reduction in the full range of emotional experience, including the emotional connection that makes intimacy meaningful rather than merely mechanical. Paroxetine carries the highest rate of sexual side effects among SSRIs. Bupropion, which works through a different mechanism, targeting dopamine and norepinephrine rather than serotonin, has a substantially lower sexual side effect profile, and in some studies was associated with improved sexual function. If you are on an SSRI and experiencing significant sexual side effects, this specific comparison is worth raising with your prescribing physician. Benzodiazepines, diazepam, lorazepam, clonazepam, prescribed for anxiety and sleep, carry their own set of concerns for male health beyond their well-documented risks of dependence. They suppress testosterone through their effect on the hypothalamic pituitary axis, the brain-based command system that regulates hormonal production, and they impair the neurological arousal pathways required for erection. Long-term benzodiazepine use in men over 50 has been associated in multiple studies with testosterone levels significantly below age-matched norms. Emotionally, the compound effect of treating one aspect of well-being while silently degrading another is something I see cause profound confusion and suffering in my patients. Men who begin antidepressants because they feel empty and then find that the medication removes sexual desire and emotional depth often conclude that the emptiness was always about their relationship or their age. It wasn't. It was pharmacology. And that is a conversation they deserve to have before the prescription was filled. Practically, if you are managing depression or anxiety and experiencing significant sexual side effects, please do not stop your medication without a plan. Instead, bring this specific concern to your physician. Ask about bupropion as an alternative or adjunctive option. Ask about phosphodiesterase inhibitors, which have evidence for partially reversing SSRI-related erectile dysfunction, if that specific symptom is the concern. And ensure your testosterone is measured, because the hormonal suppression associated with long-term benzodiazepine use is both real and, in many cases, reversible with appropriate management. Number 5. 5-alpha reductase inhibitors, finasteride and dutasteride. I have saved this one for last because it is the most directly relevant to urological practice, and because the sexual side effects associated with this class of medication remain among the most underreported and underacknowledged in all of men's medicine. Finasteride and dutasteride are prescribed for 2 conditions: benign prostatic hyperplasia, enlarged prostate, and male pattern hair loss. They work by blocking the enzyme 5-alpha reductase, which converts testosterone into dihydrotestosterone, or DHT. DHT is a more potent androgen than testosterone and is responsible for prostate growth and hair follicle miniaturization. Blocking its production reduces prostate size and slows hair loss. Here is what the prescribing conversation often omits. DHT is also a critical neurosteroid. It plays a direct role in the nervous system's regulation of sexual desire, genital sensitivity, mood, and the central processing of sexual stimulation. When 5-alpha reductase is inhibited, DHT levels fall throughout the body, including in the brain and nervous system. The result, in a subset of men, is a syndrome of sexual side effects that includes reduced libido, erectile dysfunction, reduced penile and genital sensitivity, and in some cases, a condition called post-finasteride syndrome, a persisting set of sexual and neurological symptoms that in some men continues after the medication is discontinued. The official prescribing data for finasteride reports sexual side effects in approximately 2 to 4% of users. Independent research and patient registry data suggest the true incidence is higher, and the incidence in men over 50, whose baseline hormonal reserve is already reduced, may be higher still. A study published in the Journal of Sexual Medicine found that finasteride users had significantly lower scores on validated measures of sexual function compared to non-users, and that these differences were more pronounced with longer duration of use. I am not telling every man on finasteride to stop. For men with significant prostate enlargement, The quality of life benefit is real, and the medication is appropriate. What I am saying is that if you are taking finasteride for hair loss, a cosmetic rather than medical indication, and you are over 50, the risk-benefit conversation looks meaningfully different than it does for a 30-year-old man. That conversation deserves to happen with your full awareness. Practically, if you are on finasteride or dutasteride and have noticed any of the sexual side effects I've described, document them specifically and bring them to your urologist. There are alternative strategies for both prostate management and hair preservation that do not carry the same hormonal consequences. Alpha blockers for prostate symptoms and topical minoxidil for hair loss do not share the hormonal mechanism of 5-alpha reductase inhibitors and may be appropriate alternatives depending on your specific situation. So here is your action plan, gentlemen. Pull out your medication list today, every prescription you are currently taking. Write down any symptoms you have been experiencing: fatigue, reduced libido, erectile changes, emotional blunting, muscle weakness, or morning flatness. Bring both lists to your next physician appointment and ask directly, could any of these medications be contributing to what I'm experiencing? Ask specifically about alternatives with better sexual side effect profiles. Ask about monitoring, testosterone levels, zinc levels, and any other relevant markers. And do not accept silence or dismissal as an answer. You are entitled to a complete picture of what is happening inside your body. Robert, the careful, compliant, quietly devastated accountant I told you about at the beginning, had his medications reviewed. His beta blocker was switched to nebivolol. His thiazide was replaced with an ARB. Zinc supplementation was added. Within 10 weeks, he came back into my clinic and sat down with an entirely different quality of stillness. Settled rather than resigned. He said, "I thought I was just getting old. I thought this was just who I was going to be from now on." He paused. "I wasn't getting old. I was being slowly depleted by things I trusted to help me." He was right, and he didn't have to accept it. Neither do you. If this video gave you something important today, give it a like so other men can find it. Leave a comment below. Tell me which of these 5 medications you're currently taking, or tell me one question this video made you want to ask your doctor. Share this with a man over 50 who is on multiple medications and has been accepting decline without knowing where it's coming from. And subscribe, because every week I bring you the honest, evidence-based, clinically grounded conversations that men over 50 deserve to be having. I'm Dr. Emily Carter. Your medications are not beyond question, and your decline is not beyond examination. Most men who look closely find that what they accepted as inevitable was, in fact, addressable. Now you have the information to start looking. Take care of yourself, and I'll see you in the next one.